So now we will have a brief review of how to examine the knee joint. So as we said earlier, every joint will be examined as look, feel, move, and special test. So the knee is also going to be examined in the same format. So again, you introduce yourself to the patient, you take consent from the patient for examination, you wash your hands, and then you ask patient if they have any pain, and then you start the examination process. So the first thing again is look. The exposure should be there, patient should be in shorts, so you can see the quadriceps muscles, you can see the whole legs clearly. So you look at the patient from the front to see any deformity of the knee, to see any varus or valgus deformities of the knee, any scars, any swellings, any deformities, and then you look at the patient from the side. From the side, you want to see if the patient has any fixed flexion deformity or if the patient has got any hyperextension deformity of the knee. Then you come to the back of the patient and you want to see if there's any swelling in the popliteal fossa, any previous scars, any varicose veins, or any other pathology that you can see from the back of the knee. And then you rotate around the patient, then you come back to the front. It's very important in every lower limb joint that you get the patient to walk, because you need to be able to see and assess the patient while they walk, and you assess their gait. So you get the patient to walk a few steps in the room, front and back, to assess the gait of the patient and to assess if there's any instability of the knee while they are walking. After you have looked at the knee, then you get the patient to lie down in the couch, and then you start the feel part of the joint. So the feel part starts with the temperature. So you feel the temperature of the knee with the back of the hand. The next thing you check is the fluid or the effusion in the knee. The two tests that we need for the effusion of the knee, one is the patellar tap test and the other is the swipe test. So we do those two tests, which we will show you in the subsequent videos how we actually perform those tests. Then you have to feel the structures around the knee, which include the patella, the joint line, which is the medial joint line, and the lateral joint line. You feel the patellar tendon, you feel the quadriceps tendon, and you feel the tibial tuberosity, you feel the proximal tibia, and you feel the distal femur. So these are all the structures that you can assess and you can feel while you are examining a knee joint. The third again comes to move. So you get the patient to move the knee. The two movements of the knees are flexion and extension. So you get the patient to fully flex the knee actively, and then you push it passively to see if there's any extra movement that you can achieve. And then you get them to extend the knee fully, and you document the range of motion of the knee, obviously. Having done look, feel, and move, we come to the special test. So special test in the knee, again, there are 4 ligaments in the knee that you have to assess properly. Number 1 is the ACL, number 2 is the PCL, then there is a medial collateral ligament, and then there is a lateral collateral ligament. There are different tests for each of these ligaments to assess the integrity of these ligaments. So for the ACL, the common tests that we perform in the clinic include the Lachman's test and the anterior torsion test. So these 2 tests we perform in the clinic. Another test commonly performed for the ACL integrity is the pivot shift. However, the pivot shift is a painful test. Most commonly it is performed in theatre when the patient is anesthetized so that they don't have so much pain. Second ligament is the PCL. So for the PCL, the 2 tests that we do, number 1 is the posterior sag sign, in which you put the 2 knees at 90 degrees of flexion, heels together, and you look from the side to see any posterior sagging of the tibia. The second thing is posterior door sign. So you do posterior door sign, which is for PCL, and the posterior sag sign, which are for the PCL. For the MCL and LCL, which is the medial and lateral collateral ligament, you do varus and valgus stress test, in which you stress the knee medially and laterally to assess the integrity of these 2 ligaments. The other structure that we do special test for is the meniscus. So the most common test we do for the menisci in the clinic is the McMurray's test or the McMurray's sign. So you flex the knee fully, you rotate it externally and extend, and then you flex it fully and you rotate it internally and extend, and you check whether it is the medial or the lateral meniscus which is damaged. Another test for the knee is for the patellar instability, and it's called as the apprehension test. In this test, you flex the knee to 30 degrees of flexion and you forcibly try and displace the patella laterally. If the patient has got a patellar instability or if patient has had dislocation of the patella before, they will actually stop you from doing it because of significant discomfort and pain. The last test that we do for the knee is for the posterolateral corner instability. It's called as the dial test, in which you flex the knee to 90 and then you externally rotate the toes and you assess the difference between the two legs. The knee with the posterolateral instability will have much more external rotation compared to the normal side. So that concludes the basic examination of a knee joint. Okay, so now we will do an examination of the knee joint. This is Dr. Shahid. We will examine his knees today. As in every other test, the first thing will be that you will be asking permission, you will be taking consent from the patient, you will be introducing yourself, you will have to wash your hands, clean hand before touching the patient, and you need to have a proper exposure. So, hi, my name is Dr. Ahsan. Is it okay if I examine yourself?
Yes, of course.
All right. So I'll be just having a look at your knee,
Sure.
making you walk, and then feeling different parts of your knee.
Okay.
If you have any pain, you just let me know.
Sure.
Do you have any pain in the knees?
No,
now?
I don't.
You don't have any pain. So, exposure is important. Can you please lift your short
Sure, of course.
as much as possible?
Of course.
So, ideal exposure of the examination of the knee joint should be that you should be able to see the quadriceps muscles completely, and it will be fully exposed so you can see any deformities and any muscle wastings. Okay, so in inspection, the first thing would be that I will stand the patient in an open space so I can see it from the front, side, and the back. So I'll be walking around the patient to make sure that everything is okay and I don't miss any positive findings. So from the front, we look for any scars, deformities, swelling, muscle wastings, any bruising, and any deformities. Now, deformities that we look for in this view is any varus deformity or any valgus deformity of the knee. So we look for any varus, so these knees look pretty straight. There's no swelling or scarring anywhere. Then I'm walking around. I go on the side of the patient and I see if there's any fixed flexion deformity here or any recurvatum or hyperextension of the knee. Then I go behind the knee to see if there's any swellings like a popliteal cyst, any varicose veins, any deformities, any scars from the past. Similarly, I'm coming to the right side now. I'm going to look at the knee from the right side to see if there's any fixed flexion or any recurvatum. And now I come back to the front, and that completes my inspection of the knee. However, for any lower limb joints, the examination is not complete unless we ask the patient to walk. So, Dr. Sheikh, can you please walk here and then go back? So we're looking at the gait of the patient. Okay, turn around please. Walk to the end. I'm looking at the way that he's walking. I'm looking at any deformities when he's walking, and you cannot see any obvious abnormality here. Okay, thank you very much. After inspection, it's feel and then move. The rest of the tests for the knee, like the feel and the move part, are done with the patient in the bed. So here we are, we're going to start the feel part of the examination now. So it starts with the feeling of temperature. In orthopedics, it's two joints always. So you have to have the two joints always exposed and examine the two joints and compare the two joints at all times. So first of all is the temperature. The back of the hand is very sensitive to feel for the temperature. So you feel the temperature to make sure it's okay. The temperature is fine. Then you feel for any tender spots. You ask the patient and look at the face of the patient. Do you have any pain anywhere, sir?
No, I don't.
Okay. I'm feeling the patella. I'm feeling the distal femur, proximal tibia, the muscles, quadriceps tendon, the patellar tendon. Then I bend the knee up to feel the joint line. Any pain anywhere?
No.
And you should ask the patient frequently if there's any joint line tenderness anywhere, any tenderness in the back of the knee, tibial tuberosity. No pain.
No.
Okay. Now the other side, again I will start with the patella. Any pain, sir?
No.
In principle, you always go to the tender spot at the last. You don't go start with the tender spot. So patellar tendon, quadriceps tendon, distal femur, proximal tibia, bending the knee up, feeling the joint line, looking at the face of the patient. Any pain, sir?
No.
Any tenderness anywhere?
No.
Feeling the back of the knee, front of the knee. No pain?
No.
Okay. So that's the feel part completed. Okay. After this, we do the move. So movement is active and passive. First will be active movement by the patient himself, and passive movement in which I will help the patient to move the knee. Okay, can you please bend this knee fully? Okay, straighten it out fully. So this is complete flexion and extension of the knee. Can you do it with the other knee, please? Straighten it out. So that's full range of motion actively. Now I'll do passive and see if there's anything that we can see. So this is full flexion of the knee, which is around 160 degrees. And this is full extension of the knee. And to check more extension or hyperextension, you just put a hand in the front and raise up the heel there. Similarly on this side, this is full extension. Now bend the knee fully, please. And full flexion. So patients with arthritis or patients with problems with the knee will have decreased flexion, and they may not be able to bend beyond 90 degrees. So you have to be able to document the range of motion of the knee whenever you are doing an examination of the knee or any tender spots that you may feel. So look, feel, move, completed. Now we go on to the special test. Now, as we discussed, that the knee has got 4 ligaments. So we start with the examination of those 4 ligaments. The most common one to be injured is the anterior cruciate ligament or the ACL. So the test for the ACL include Lachman's test, anterior drawer test, and a pivot shift. So I'll show you how to do these tests. So Lachman test, you relax the knee fully. You make sure that the patient is fully relaxed. So just relax the knee first, and then you hold the knee from the below the knee and above the knee at the thigh and the upper leg, and you move it front and back. So your movement is this. This is the movement that you're doing, and you're trying to see if you are able to move the knee or if the knee is unstable. This is the Lachman's test, and then you compare it with the both sides. You never do it one side, always do both sides. Second test is the anterior drawer test. You bend the knee to 90, both of them, and then you stabilize the toe of the patient, sit in front. You relax the hamstrings, your hands over the proximal tibia, thumbs around the tibial tuberosity, and move it forward. In patients with ACL deficiency, there will be exaggerated movement anteriorly of the knee, and the knee will feel unstable. You have to compare it with the other leg. Again, doing the same test. This is called as the anterior drawer test for the ACL. The third test, as I said, is the pivot shift. A pivot shift test is quite painful. It's not advisable to do it in the clinic. It is generally done with the patient sleep in theater just before we are going to do an ACL reconstruction for that patient. Now, the second ligament to be tested is the PCL, or the posterior cruciate ligament. The test for the PCL include the posterior sag sign or the posterior drawer test. So for posterior sag sign, you put the heels together, you put the knees together, and you look at the tibia from the side to see if any of the tibias is sagging posteriorly. So in patients with PCL deficiency, one of the tibias, either the right or the one or the deficient side, will be displaced posteriorly, and you can actually see it from here. So you put a hand here to feel anyone else going more posteriorly, and more importantly, you see it from the side. The second thing that we do for the PCL is posterior drawer. So same, right, the anterior drawer will push the knee forward, and the posterior drawer will push the knee backwards. And we see if the tibia is being pushed backwards or displaced backward while doing this test. So this is the test for the PCL deficient knee. The other two ligaments in the knee are the MCL and the LCL. That is the medial collateral ligament and the lateral collateral ligament. So you test them by holding the knee straight up and putting a valgus stress force to open up the medial side, and similarly pushing it inside to see if the lateral side opens up. And you repeat this test in about 30 degrees of flexion. So external pressure, valgus, and then varus pressure. And again, you compare the two knees, medial and lateral, done in 30 degrees of flexion and done with the knee straight. Okay, so these are the 4 ligaments tested. Another special test for the knee is the McMurray's test for the meniscal injury. Now there are 2 menisci, medial and a lateral, and in McMurray's test, we flex the knee fully like that, and then we rotate it and bring it out. And then we flex it again fully and rotate the other way and bring it out. And you see and feel which side is tenderness. So it could either be medial tenderness in cases with medial meniscal injury, or it could be a lateral sided tenderness in patients with lateral meniscal injury. And again, you repeat this test for both knees. Full flexion, rotation of the ankle at the knee joint, and then the other way, and you check if the patient has medial or lateral joint line tenderness. Any pain anywhere?
No.
Okay. Another test for the knee is testing for effusion in the knee. Now, for effusion of the knee, there is a patellar tap test. In patellar tap test, we bring all the fluid down by squeezing down the fluid from the suprapatellar pouch, and then with the thumb or the fingers, we push the patella down, and in positive test, you will feel a tapping of the patella onto the femur. So, if you feel that, it means that the knee has got some fluid inside, and you repeat the test for both knees to see if there is any patellar tap. If there is minimal amount of fluid in the knee, then there's a swipe test. In the swipe test, we first empty up the medial gutter of any fullness of any fluid inside, and then you press the lateral side, or you squeeze the fluid from the lateral side. If the medial gutter fills up, that means that it's a positive test. There's a effusion inside the knee. And again, you repeat it for both knees. So one more special test for the knee is apprehension test for the patella. And this happens in patients with recurrent dislocation of the patella or instability of the patella. So the way to do it is that we flex the knee to about 30 to 40 degrees, relax the knee fully, look at the face of the patient to make sure that he is comfortable, and then with the thumb, we push the patella outside. Can you please relax the knee fully? Leave it down, yes. So here I'm pushing the patella out and I'm looking at the face of the patient. Any pain when I do that? Okay. So in patient with the positive apprehension test, when I'm pushing the patella out, they will tell me to stop and they will become very apprehensive about it. And I can actually fully dislocate the patella laterally. Similarly, we repeat the test with the other side, flexing the knee to 30 to 40 degrees. Relax the knee fully, please. Leave it fully loose. And now I'm pushing the patella outside and I'm looking at the face of the patient to see if he is comfortable. In patient with a positive test, they will stop me from pushing the patella out and they will become very apprehensive. So when the patella is stable in the groove, it means that it's a negative apprehension test. Thank you.